Okey, you all semua dah ada dah? Semua dah ada dah?
Ya, Doktor. Semua dah ada dah.
Okey, start.
Okey. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay, thank you everyone for attending our seminar today. Thank you to Dr. Tu for being our supervisor for this seminar. Today's seminar is under the theme of tropical infection. You can see my background also. Tropical, right? Okay, yeah. So the tropical infections will cover certain topics such as dengue will be presented by me, Muhammad Zakwan Abdul Rahman. Childhood TB by Brother Musawa. Then pertussis and diphtheria by Atikah Gadi. Malaria by Sister Edina Hisham, and finally the leptospirosis by Hanis Hamdan. Okay, so without further ado, let's begin. Okay, the first one, let's look about the dengue fever.
Siapa lecture dulu ni? Siapa beri dengue fever dulu?
Masa BMS ke?
Tak, seminar ni siapa beri yang topik pertama apa?
Dengue fever.
Year berapa ni? 3.
Year 3. Group 4.
Oh.
Tapi jadi dia macam bercampur tu.
Kenapa pula?
Kan? Betul lah. Sebab dia kan musawa kan?
Berapa orang semua ni?
Total ada 5 orang tu untuk tropical infection ni.
Tak, berapa orang semua yang ni? 37. Group 3 je lah. Year 4. Group batch apa ni? Blok apa ni? Blok
2, Doktor.
Blok 2, ha.
Doktor, kami group A, Doktor.
Ha?
Group A.
Okay.
Siapa dulu speaker ni?
Zakwan, Doktor. Muhammad Zakwan.
Zakwan ya?
Zakwan, betul.
Zakwan. Okay,
Rahman.
now start. Start now.
Okay. Okay, let's continue. Dengue fever. Okay. On 16 June 2020, by New Straits Time, Dr. Nur Hisham lah, it said that Malaysia is seeing an upward trend in dengue cases with an average of increase of 8% each week. So we will see further about the epidemiology of the dengue fever. Okay. Okay, so this is my outline. We have about facts, which is the introductory phase, epidemiology, risk factors, classification, clinical phases, investigation, principal management, and last one is the extra one. I included about the controversial thing about the dengue vaccine. Okay. So what is the facts of the dengue fever that we must know? That dengue fever is caused by a dengue, which is it is actually a virus type of in the Flaviviridae group. It has 4 serotypes, dengue virus 1, 2, 3, and 4. But in Malaysia, we have the dominant one is the type 1 dengue virus, while type 3 and type 4 is commonly found in the America lah. Okay, so we must know that the dengue virus is a arthropod borne. It is spread via 2 types of mosquito, which is the Aedes aegypti and the Aedes albopictus. The Aedes aegypti is the one that usually live in the very urbanized area, which is in our hometown lah. Basically, kan? In a very stagnant water. It is not usually a very clean water, right? It is different from the Aedes albopictus. It needs a very clean water to live, right? So mostly Aedes albopictus we can find in the jungle, basically. So incubation period of the dengue infection is about 5 to 6 days before the patient try to come with sign and symptoms. Okay, so this is the facts that we must know. The next one, this is the epidemiology. Worldwide, we have about 4.2 million cases reported in 2019. I got these numbers from the WHO that this report is updated in the last October in 2019. 4.2 million all over the world. While in 2010, 10 years back, we have about 2.4 million cases only. See about the increment, it is very significant, right? So worldwide, we have about 2.5 billion people who are at risk, over 100 countries. Mainly these countries in the tropical and the subtropical region, but the subtropical region is the main higher risk to get the dengue infection. Okay, so let's see. In Malaysia, it is reported until October 2020, it is reported about 82,753 of dengue cases. Well, we know that this currently we have COVID, right? COVID is about 10 months. We are dealing with COVID, and this COVID has the cases have been reported about 72,000. So dengue is about 82,000. So it is very high, actually. It is very high. So okay, so we can see the spread of the disease. Actually, where is the habitat of the arthropods, the mosquito? So there will be dengue cases. Okay, we can see in the red colors mainly. We can see at the subtropical region, mainly in Malaysia, Philippines, in the Thailand. See, you can see suitable for both Aedes aegypti and albopictus. So this is why about most of the subtropical region is very high risk to get the dengue virus, dengue infection. Okay, so what are the risk factors that can lead to the dengue fever? Is the urbanization, because between the two types of mosquito, Aedes aegypti and the Aedes albopictus. Okay, Aedes aegypti is the most predominant that could breed the dengue virus. Okay, so we know this dengue aegypti always breed in the urban area. So urbanization is one of the factors, because it provides the suitable condition for the mosquitoes breed. Okay, and then being at the tropical and subtropical region. So any patient which have the travel history, or his house living at the tropical or subtropical region, in the American region, in the Southeast Asia, so this we actually have the higher risk to get the dengue virus. Okay, so okay, I forgot to say that annually we have the highest cases come from the Selangor, from the Klang area. So be careful anyone from Klang. Okay, So WHO has come with a classification of the dengue infection. Okay. So this is I quote from the expert consensus group in Latin America, WHO 2008. They said dengue is one of the disease entity with different clinical presentations and often with unpredictable clinical evolution and outcome. So from this statement, what is the first impression of us? We can say that the dengue virus presentation from the patients is very dynamic. So it is it may be viral, it may be dengue or maybe not. Okay, so let's see that, inshallah. So WHO classified it into two sets: dengue infection with or without warning signs, and the severe dengue. Okay, so dengue virus, the important things that we must know that it is a self-limiting disease. About 20 to 30% of the patient usually have the dengue fever, but they are self-limiting about 7 days, and then they resolve. Okay, but most of the patient, they will come with the more severe presentation. So we will see. Okay, see, we have the with or without warning signs. Okay, what is the important of the warning signs? Warning signs, usually patients will comes with the warning signs that will have high risk to develop a severe dengue. Severe dengue is a latest term that used to describe dengue hemorrhagic fever. This more we common with, and the dengue shock syndrome, right? So nowadays we call this severe dengue. In bracket, dengue shock syndrome. Dengue shock syndrome. Okay. Okay. So we will go one by one. The probable dengue, we can suspect the patient with dengue if the patient have live or travel in the endemic area, tropical, subtropical region. We have the fever with the two following criteria: nausea, vomiting, rash, the maculopapular rash, aches and pain, tourniquet positive test. Tourniquet is the test that to assess the hemorrhage extent, and any warning signs. Okay, warning signs, as I said before. Okay, so what are the warning signs? Is the abdominal pain, the abdominal tenderness, persistent vomiting and diarrhea, clinical fluid accumulation, mucosal bleed or any bleeding, lethargy and restlessness, liver tenderness, and the laboratory, we are expecting these patients to have the increase of the hematocrit, okay, and rapid decrease of the platelet count. And the severe dengue, which they extend, is a certain condition that I'll be talking later. Okay, is a severe plasma leakage that we are afraid of. This patient will develop shock of fluid accumulation within the respiratory distress, with the respiratory distress, severe bleeding, okay, and the severe organ involvement, liver, CNS, etc. Okay, so this is the part that we need to stress about, the clinical phases of the dengue fever. Okay, so WHO, the experts in the WHO has come with the three clinical phases of the dengue. Okay, we can divide it into the febrile phase, critical phase, and the recovery phase. Okay, along these phases, it takes about 1 to 10 days for this period of time. Okay. Yeah. Okay, so the first one is a febrile phase. We will go this one by one. Okay, febrile phase, you take about 3 to 4 days. The critical phase is the phase that we are afraid of, the dengue shock syndrome, etc. occurs here, and the recovery phase when the patient is resolved from the knee. Okay. So in the febrile phase, what we can find is that occurs after the incubation period. As I said before, the incubation period of the dengue virus is about 5 to 6 days, and the day 7 will be the first presentation of the patient. It lasts for 2 to 7 days, usually. Okay. So the clinical presentation, usually the patient comes with the facial flushing, or actually it's a maculopapular rash. It's a very slight and some raised lesion along the face and along the on the skin. Generalized body ache, such as nausea and vomiting, sore throat, and maybe come with the mild hemorrhage. The particular hemorrhage, the mucosal hemorrhage. Okay, mucosal hemorrhage, we are talking about the gingival bleeding, mostly in the the about 20% of the patient will develop a mild hemorrhage, mainly at the mucosal bleeding, the gingival bleeding, and the per vagina. It is found in some of the patient, but it is very rare in the febrile phase. Okay, so and any when we are examining when we are examining about the patient, enlarged liver and tender liver is one of the warning signs that we must be aware of. Because these, when the patient have the tender liver and enlarged liver, this patient have the tendency to move into the next phase, which is the critical phase. Okay, the critical phase. Okay, so who are the people, who are the patients that will move to the critical phase? Those who are the immunocompromised patient, and the second one is the second group that is the second exposure of different serotypes dengue. Okay, as for example, I'm the before this 3 months later, 3 months before, I was infected with the dengue virus type 4, and today I am infected with dengue virus type 1. So the exacerbation of the of the uh, of the immune response that will lead to the critical phase. Okay. So critical phase, which means not all patient and not all patient will move to the critical phase. That's why in the first place I said that it is a self-limiting disease. Okay, so the critical phase, it is very severe cases. This will occur about third day of the fever. It will after there will be a rapid temperature drop, which is this in this phase the most of the patient will have the shivering phase. Okay, and the clinical presentation include the plasma leakage that can lead to the dengue shock syndrome. Okay, so the organ damage may occur at this stage, and most of these patients will develop compensated shock, and if we not attend the patient, it will proceed to decompensated shock. Most of the patient will have abdominal pain, persistent vomiting and diarrhea, and most of the patient in the critical phase will mostly likely to develop the mucosal bleeding and the liver tenderness. This is we call as dengue hemorrhagic fever. Okay, and as I said that in the classification before, thrombocytopenia, the hemo concentration is a warning sign of the so in the critical phase, this is what we must keep observing, keep monitoring in this patient during our management, and high hematocrit will be noted, but however it is very it is difficult to assess because during the critical phase, the clinicians will usually resuscitate the patient, and so about the thrombocytopenia. Why is the dengue fever associated with thrombocytopenia? There's two hypotheses. The first one, there is research that said that they found the dengue fever, the dengue virus invade the bone marrow and cause bone marrow destruction. And one research and one other theory say that the exacerbation of the immune response lead to the destruction of the peripheral platelet. Okay. So what are the hematocrit happen occurs before the because when in the blood vessels when there is a plasma leakage, the plasma move into the third space. Okay. So there will be apa ni, orang Melayu cakap ni lah apa tu, darah pekat lah kan. There are a lot of hematocrit where there is less plasma in the blood vessels, so there will be high hematocrit lah. So this is the features of critical phase of dengue fever. Okay, so once again we are being exposed with this table about the shock, compensated shock and decompensated shock. Okay, so whenever patient come with the compensated and decompensated shock, we can but mainly in the compensated shock, we must immediately attend the patient because we do not want the patient to have a decompensated shock, which is less likely, which is more difficult for the physician to manage the patient. Okay. So next is the recovery phase. So this is all the patient will go through this phase. After the critical phase is about 2 to 4 days of the critical phase, the patient will improve. So in this patient, in this phase, the patient will come with the eyelid of white in the sea of red, which is it is actually maculopapular rash lah, in the patient, and some of the patient, about 20 to 30% of the patient will complain about pruritus and the persistent myalgia. And persistent myalgia, all of this clinical presentation is because of the IgM and IgG of the towards the dengue has been developed. So this is kind of side effects of the IgM of the antibodies that produce. Okay. Okay, so what are the investigation of the that we can do? We have to about the because this is a very monitoring. This is a self-limiting. So you must monitor. And what is diagnostic? So to monitor, we must assess the full blood count. We are expecting white blood cells to reduce, and platelet. We have the thrombocytopenia. The hematocrit, sorry, the hematocrit will be increased, as I said, as I explained before. We must assess the liver function test before because it indicates a very high inflammation, high AST or ALT, coagulation profile to assess the thrombocytopenia, the blood gases to stabilize the patient, and tourniquet test to assess the extent of the hemorrhage in the patient. And what is the diagnostic? In Malaysia, we usually do the RT-PCR, the reverse restricted PCR. Okay, this is very diagnostic. However, in Malaysia, we are more looking forward to the rapid combo test, which is it costs 60 ringgit per test in Malaysia to be done. However, this facility is only available in the research university, such as UM. I'm not sure about IUM, ni SASMED, I don't sure. And the other one is the dengue antigen and antibody test. We can do this too. Okay, so how about the management? How we want to manage the patient? Okay, we manage the patient based on the phases or the critical phases. Okay, more the patient will come with the febrile phase. usually we give them symptomatic treatment, the palliative care, which means if they have fever, we give antipyretic. They have the myalgia, we give them PCM. Okay, maybe some of the patient will need analgesics, but bear in mind that we cannot give the aspirin, because the aspirin will make the patient to have more exacerbation of the bleeding tendency. Okay, and we don't want the patient to proceed to critical phase. And less of the patient need the fluid replacement therapy. Okay, and the critical phase, usually we will give the fluid and crystalloid replacement to the patient to stabilize the patient, to treat the shock. Then we may do the OGDS to see for the hemorrhage within the GI, and we must keep on monitoring the platelet count, the hematocrit count, okay, for this critical phase. And the last one, recovery phase, it is self-limiting, so there is no need for treatment. Okay, how about the dengue vaccine? Okay, dengue vaccine, as we discussed before, we have a session before, right? It is very controversial. We have a lot of problems going on in this dengue vaccine. So we hope for the best. They are planning about 2021, but it may be delayed due to the COVID pandemic. So we pray for the best, inshallah. Huh? Okay, so one most important thing that I forgot to mention earlier, that the dengue virus is a clinical apa ni? Which means, sorry, I speak in Malay. We must we detect the dengue fever clinically. Okay. So it is rarely for us to do the RT-PCR, except for in the research university. So this is my source: Command Clark, WHO, MOH, CPG, and Science Direct. Okay, so thank you. Any question?
Any questions? No question. Okay, next speaker, presenter. Nick Al-Musawa.
Yes, sir. Assalamualaikum warahmatullahi wabarakatuh. My name is Ni Al-Musawa bin Muhammad Hamran, metric number 1812615, and I'll be presenting today about childhood tuberculosis. So, Bismillahirrahmanirrahim. This will be the presentation outline. So the topic we'll be discussing today or will be presented today is about childhood tuberculosis. So the definition by WHO about tuberculosis itself, it is defined as a disease caused by Mycobacterium tuberculosis infection that usually affects the lungs, but it can also affect other parts of the body. So by that means said, childhood tuberculosis means tuberculosis disease or tuberculosis infections in children less than 15 years of age. It is a chronic disease that has a period of latency that might turn into a reactivation phase and causes secondary infection. So let's talk about the etiology of this disease first. The organism or the causative agent is none other than Mycobacterium tuberculosis. It is a weakly gram-positive bacteria with a slender, slightly curved rod shapes, and they grow in branching chains. And the most unique thing about this organism, they have a high lipid constituents, which consists of a mycolic acid as well as the waxy cell wall. and this what makes them called as acid-fast bacilli. And this constituent also makes them very dangerous, or they cause severe disease to us. So they are non-motile organism, they are non-spore forming, and also strictly aerobic and slow growers. So it takes about 6 weeks to grow them in solid media and about 3 weeks to grow them in liquid media. So next is about the epidemiology of the disease itself. Tuberculosis itself, according to WHO, 1/3 of the world population is affected by tuberculosis infections, and most of them manifest latent infection rather than active tuberculosis. And about 9 million of cases reported worldwide are reported each year for tuberculosis infection, and about 1 million infection in children. And this is a very serious disease because about 1 to 2 million deaths reported by the WHO annually are attributed to tuberculosis infection. So this is a map from WHO which shows the prevalence of tuberculosis infections around the world. And this is a table which I get from the National Strategic Plan of Tuberculosis Control 2016-2020 from the Ministry of Health, Malaysia. So this this table shows the prevalence of tuberculosis disease as general in Malaysia. So about 24,220 cases were reported in Malaysia in 2015, and Sabah was recorded to have the highest prevalence of cases, followed by Selangor as well as Sarawak. And this is a graph. This is a graph shows where in the studies they classify based on age group specifics. So we can see here in Malaysia, more than people with more than 65 years old are very much infected with tuberculosis infection, and a very small numbers, not significant numbers of tuberculosis infections among child are reported here, but also important for us to note about that. And this is a further classification where we include BCG vaccination coverage in the equation of our studies. So we can see here what the importance in this graph here. Although we can see from the year 2000 to the year 2015, although almost 99% of children were covered or vaccinated by BCG, but still there is a case of tuberculosis infections among children. So in the textbooks also said that BCG vaccination, although it is protective, but the protection is not complete. Meaning to say that children, although being vaccinated with BCG vaccine, they still can have a chance to get infected with tuberculosis, but the chances are lower than those who did not take BCG vaccination. So moving on, next is the transmission of the disease. We know that tuberculosis, Mycobacterium tuberculosis, is a pathogen of the respiratory tract. So they get spread from person to person through respiratory droplets. More specifically to say, this organism resides in the droplets nuclei. So when the infected persons, when they talk, sneeze, cough, or even breathe sometimes, they may release the infected particles, the infected respiratory droplets in the air, and becomes airborne. And once the respiratory droplets becomes dry, they will form the droplet nuclei. And this droplet nuclei, they can reside in dust and can be spread to a distant region, or they can also reside or settle down around the patient's body and clothing, making them infectious. And when this droplet nuclei, this infectious particles being inhaled by a healthy normal person, because of the small small size micrometer of these droplets nuclei, they are able to evade the defense mechanism by the upper respiratory tract, and reaches the lower respiratory tract and also the alveoli. But in children, specifically, they rarely become infectious or they rarely infect others through this type of transmission, because in children, they are reported in several studies that they have low bacillary load in the endobrachial secretions, and also in children, they have lack of QC force to produce a very powerful and forceful cough to suspend the infectious particle in the air. But and that is why in several studies and researchers shows that most children got infected with tuberculosis from contacts with their households as well as from their parents. And most outbreaks that can be seen are in schools and also daycare centers due to the crowding. And also immunodeficient patient and also some patients with biological response modifiers have higher or increased risk to get this transmission of this disease. So this is the pathogenesis of the tuberculosis infections. Once the healthy person inhaled the infectious particles will the organisms, tubercle bacilli, will get into the lungs, which will then cause an activation of the immune response. So there will be release of chemokines as well as the as well as the cytokines, which will later on activate the monocytes and the alveolar macrophages to engulf and kill the Mycobacterium tuberculosis. But because of their specific characteristics to have the cell wall, because of their special cell wall, they may evade killing of by the macrophages, and they may multiply in the inside the macrophages itself, which will later on resulting in exudative inflammation inside the lung parenchyma. And from this, there may be two outcomes. First, when the immune response failed to control the infection itself, the infection may get spread to a nearby region of the lungs, or they may get spread to the lymphatics, and they may be carried into the regional lymph nodes, causing lymphadenitis, or they may also enter the blood vessels where they can get widely spread through hematogenous spreading, which will cause a condition where we call as a miliary tuberculosis. But most patients, the other condition is where most patients usually have is when the immune system is able to control the infections. So the Mycobacterium tuberculosis will remain dormant inside the macrophages. And in this condition, the patient is said to have a latent tuberculosis, where the patient with latent tuberculosis, they are asymptomatic as well as non-infective. But when we do tuberculin skin test as well as the interferon gamma release assay test, the result will be positive. But for patient with latent tuberculosis, when should the immune system become suppressed or become down, the Mycobacterium tuberculosis may begin to multiply rapidly and will cause a reactivation. In this condition, we say that the patient have secondary tuberculosis. This is the classification of tuberculosis. We have primary and secondary, latent and active, pulmonary and extrapulmonary tuberculosis. In primary tuberculosis, it is the first encounter with the pathogen itself, and there is an exudative inflammation, and it may progress to spreading, causing miliary tuberculosis, or it can remain dormant, as what we have said before. And the usual presentation in chest X-ray might show Gone complex. Gone complex is when there is a lung lesion, a lesion in lung parenchyma coupled with the hilar lymphadenopathy. This is what we call as Gone complex, and this usually affects the middle and also the base of the lobe. Next is the secondary tuberculosis. It can either be reactivation, as what we have mentioned before, or it can either be a reinfection by the same bacteria itself. And from the primary tuberculosis, it may remain
Those two pathogenesis yang pergi kan.
Yes, sorry, Dato.
I beritahu you all, I pukul 2 ada meeting. You all siap tak siap, I just stop. Okay. Because you still go pathogenesis dia. You banyak lagi tau. Berapa slide you ada?
39.
Hmm?
39, Dato.
Eh?
My slides is
Berapa slide?
39.
59. I tengok.
Yes.
I found out makin lama makin tak apalah present continue. Tapi I rasa the few things yang perlu lah. Continue.
Okay, yeah, I will speed up a little bit.
Tak apalah ha. This
Okay,
one you learn masa you belajar dekat ni. You ada belajar tak masa you ni?
Yes, ada Dato.
Ha.
Okay.
I'm
That's-
interested in clinical presentation.
Oh, okay. So that I
Cepat
will
pergi
speed
ni.
up. Okay.
Ha.
Okay. So secondary tuberculosis. So like I said before, it can be a reactivation or reinfections. So this is a latent tuberculosis, just like we mentioned before, and this is an active tuberculosis. So the importance of to know about latent and active TB is that we have a different management for latent and also active TB, which I will explain later on. Okay, so this is a extrapulmonary tuberculosis, which one of the most important extrapulmonary tuberculosis in children, usually
Can
affecting.
you go for clinical finding terus?
Oh, okay. So usually in tuberculosis meningitis.
Apa clinical finding dan TB in children? Apa finding dia? Coughing, complain dia apa? She complain dia.
Oh, in TB, the clinical manifestation or the presenting is usually
betul balik dalam masa.
fatigue, weakness,
Ini
fever,
kita
night
ini
sweats,
tak apa
loss of
itu
weight,
lama
and
yang
signs.
ini if you want to go lama tak apa.
Oh, okay. So usually there will be children will present with chronic cough, usually for 3 weeks or more, which we might indicate pulmonary TB. If there is coupled with hemoptysis, there might be signs of far more advanced lesions such as the erosion of the bronchial lining and so on. So there might be chest pain. And on auscultation, we might find abnormal breath sounds or bronchial breath sounds, and as well as crepitation, which might indicate lung consolidation. And when we do percussion, sometimes we can have dullness, stony dullness, which may indicate pulmonary pleural effusion in some cases of TB, specifically if the TB infections infect the pleura. So this will be the
That's all.
investigation.
You punya physical finding.
Yes.
This is the thing that you want to know clinical. Oh, banyak lah. If you want to focus on this. This is more important for you all. Satu slide saja.
Yes.
Pathophysiology patology berpuluh slide.
Oh.
This is the key for your learning on the clinical. Bukan yang the first 4-5 topik slide earlier. Banyak lagi tau. Clinical manifestation ni. Daripada apa tu? History, physical finding. Bukan yang ini saja.
Okay, so as well as the extrapulmonary one, the manifestation for the extrapulmonary ones. Oh, okay, I forgot about.
Forgot apa? Bukan you fokus satu benda yang tak penting.
Oh, sorry, Dato.
You continue.
Okay, so this will be the investigation. So the first investigation, this is a screening test actually, we call as a tuberculin skin test or the Mantux test. It is an intradermal injection of 10 tuberculin units of purified protein derivative standards on the surface of the forearms. So for the Mantux test, about more than the induration of more than 10 millimeter is considered as positive, which is based on the Malaysian guidelines. But we may also consider for false positive results if in patient with previous BCG vaccination. And also we may consider for false negative results for patient who have early, who is in early illness state or have an overwhelming TB infections, or even infections with immunocompromised states, such as in HIV patients or patients with receiving chemotherapy and or organ transplant. And the next test is IgR interferon gamma release assay. It is a blood test actually, which measures a person's immune response, to be specifically the T cells response to a specific mycobacterial antigen. This test it have the same sensitivity as the tuberculin skin test, but it is a lot more specific than the tuberculin skin test because it detects only mycobacterial antigen and not and do not detect the BCG. So, but still, the disadvantage of using this test is that it detects all kinds of mycobacterial antigens, mycobacterial avian complex, mycobacterium bovine, and so on. So this is one of the disadvantages of using this test. And this is a table which which I get from Nelson.
Tak payahlah, forget about it.
Okay. So the gold standard in diagnosing TB
lah.
tuberculosis.
Apalah.
So the gold standard for diagnosing TB itself is sputum acid fast bacilli culture, which usually we culture on the solid media, the Lowenstein Jensen, agar, and also Middlebrook 7H10 and 7H plus, 7H11, and also we can do culture in liquid media in Middlebrook 7H9. So the samples usually we get from the sputum, but in children less than 8 years old.
Dalam exam kan, you tahu tak, I don't ask all this thing from you all tau. I more ask about clinical finding, tak apalah. Tak apalah you menyusahkan diri you all. Orang lain buat investigations, culture smear, PCR, tak payah ada detail pun. The detail will come in physical finding, gender examination, test the detail. Continue lah.
Oh, okay. So usually we cannot get sputum from the child less than 8 years old. So we do gastric washing. Why? Because children usually they swallow the sputum. So we do 3 consecutive morning because we need to have 3 samples for cultures. Then we examine microscopically, and after getting the positive culture results, we will do a drug susceptibility testing, because due to the increase of the multi-drug resistant TB cases now. And also we can do PCR, which usually can be proven useful in if there is a CNS involvement. Next is the imaging or chest X-ray. Usual presentation is the gone complex, or sometimes when there is enlargement of the lymph nodes around the bronchial, it will compress the airway, which will cause an air trapping, hyperinflation, and also lung consolidation, lung collapse. Adolescent may present with the same presentation of the tuberculosis infections as adults, such as the cavitations and also the apical infiltrates and so on. Sometimes there might be pleural effusion, calcification, and also calcification in lymph nodes can be seen if there is a heat lesion. And sometimes in TB meningitis, we can do CT scan and also MRI of the brain. This is a test X-ray. And next is the treatment and management. So the treatment and management for TB usually requires multi-drug regimens of isoniazid, rifampicin, pyrazinamide, and ethambutol, which we need to consider for the drug susceptibility testing. Ethambutol usually we give for a very severe manifestation of the tuberculosis. And for children, usually we give short course therapy, which consists of 6 months course of therapy, 2 months of initial intensive phase, and 4 months for continuation phase. And in the intensive phase, it is required to take daily dosing of isoniazid, rifampicin, and pyrazinamide. Whereas for continuation phase, the WHO recommends for daily dosing, but for some children with difficulty for daily dosing, which may consider for the thrice weekly or intermittent dose, but for isoniazid and rifampicin. And this is the table from TPD, which indicates for different treatments for different conditions of for TB tuberculosis infections in children. And this is a dose for daily dosing as well as the intermittent dose. And this is a treatment for latent tuberculosis where we give isoniazid for 6 months or isoniazid and rifampicin for 3 months. And for multi-drug resistant TB, children with contact with multi-drug resistant.
Tak payah.
Okay.
We don't go to ask you about those things. No.
Okay.
Ini tak payah. Ini continue.
Okay, so the prognosis is in children.
Drug toxicity tadi pergi balik.
Sorry, Doctor?
Drug toxicity.
CCT.
Drug toxicity tadi pergi balik.
Oh, toxicity. Okay. So part of the management also is we need to monitor drug toxicity. Usually we monitor the baseline transaminase and also the serum bilirubin, which is indicated in patients with severe TB disease, with a patient who have symptoms of hepatotoxicity or have underlying hepatic disease, or patient who have usage of other hepatotoxic drugs, and also patient with immunocompromised states such as the HIV infections. And children who take salbutamol should be monitored for visual acuity and color discrimination, because this might be this is one of the side effects of using these drugs. And this one is a TB, mother with TB, breastfeeding with mother with TB. So lactating mother who is non-infective and on TB treatment can still breastfeed her children, because it's said that only a minimal dosage of drugs enter the children. But if the mother is infective and have active disease, you might consider to have a specific precautions, such as need to be separated from the infant, from the child for at least 1 week, or if she wanted to breastfeed, she needs to wear a face mask while breastfeeding, and she need to do this until her sputum smear is negative results. And breastfeed is actually best avoided, but one way is to do express breastfeed for the child. And the infant and also the close household contact should be evaluated for any TB infections, which is one of the precautions of TB infections. And this is the prognosis. So the prognosis in infants, children, and adolescents are excellent, especially with early recognition and early chemotherapy intervention. And children with pulmonary TB usually resolves and have a normal findings. But in some cases where where in tuberculosis infections, children manifested with tuberculosis meningitis usually occurred in non-developing country, the prognosis is not quite as good as the pulmonary tuberculosis itself. And the prognosis become worse in resistant case of tuberculosis. This is a prevention for okay. Okay, so this is the references.
So you see, I'm sorry to say that many of the things you beritahu satu benda terlalu detail not for you all. You're wasting your knee, because for us, for you all, is to diagnosis, differential diagnosis. How to see the patient come with what condition called TB, and then how you diagnosis it, how you make differential diagnosis. Wow. That's about your level. Even drug pun sebenarnya your level tak perlu tahu sangat. Your level. I found out you buat benda banyak akan menakutkan diri sendiri. Bila come to important thing, clinical, very little. And even you can touch a little bit. So you will it's a TB, just TB as a pulmonary TB, then the TB ialah latent TB, active TB, cukup lah for you all. I think I tak tahulah. Compare the last group taklah complicated sangat present macam you all present ni. I found out mungkin tapi the last group pun stay dalam tu juga. You're posting clinical tau. Clinical means that we expect you to tell us more about clinical, not about theory. Very disappointed clinical based satu slide saja. Your investigation more than clinical. Investigation pun too detail. Nak tahu apa pasal CT scan MRI, not your level. Next presenter. Okay,
Bismillahirrahmanirrahim. Can you hear me? Okay, my name is Atika, and today I will talk about the malaria. Next slide. Okay, these are my learning objectives. First, we will go through the introduction, which consists of definition and epidemiology. Next, we will go through the etiology, life cycle and pathophysiology of Plasmodium, risk factors of malaria infection, clinical features of malaria infection, complications of malaria infections, congenital malaria, investigation, and last but not least, management. Next slide. Okay, for the introduction, actually the words malaria comes from two Italian words, which are mala and aria. So previously,
when you put a slide kan, you don't put a slide like this. So crowded. Tahu crowded tak?
Yeah, sorry,
You
doctor.
tahu crowded tak apa?
Yes, I know.
Crowded.
Okay, I'm sorry.
Continue
Okay, so previously they thought malaria is results from breathing in bad air, but until 1880, the malaria parasite is first discovered. So the true definition of malaria infection is malaria is a potentially life-threatening parasitic disease caused by infection with a Plasmodium protozoa transmitted by an infective female Anopheles mosquito. Okay, next we move to the epidemiology. So for globally, malaria, before slide, the previous slide. Okay. Malaria infection is a worldwide problem with transmission in more than 100 countries with a combined population of more than 3.2 billion people. So it means that malaria infection can cause many huge cases. In Malaysia, malaria infection was reported even before 1916. And after the introduction of malaria eradication program, the numbers of malaria cases has decreased drastically. And this currently, Malaysia has been identified by WHO as one of the 21 countries having the potential to eliminate the human-only species Plasmodium by 2020. This exclude the malaria infection that caused by Plasmodium knowlesi, because Plasmodium knowlesi is a zoonotic Plasmodium. And it is reported also majority of malaria cases occurs in Sabah and Sarawak. Why malaria infection is very important infection in pediatric? Because this malaria infection cause high morbidity and mortality among children. This is reported in 2018, where WHO stated that more than 2/3 of malaria deaths were among children under 5 years old. Next slide. Okay, for the etiology, we have the species and the vectors. So for the first species is the Plasmodium falciparum, where this Plasmodium falciparum cause malignant malaria because it causes many severe complications and also irregular fever. Next, we have the Plasmodium vivax and ovale, which cause the tertian fever, where fever reoccurring every 48 hours. Next, we have the Plasmodium malariae, where it is cause the quartan fever, where the fever occurs every 72 hours. And lastly, we have the Plasmodium knowlesi, which cause the daily fever. For the vectors, we have the Anopheles, female Anopheles, where worldwide distribution, we have the Anopheles gambiae, and for the Peninsula Malaysia, we have the Anopheles maculatus. And for the Sabah, we have Anopheles balabensis. For Sarawak, we have Anopheles donaldi. Next slide. Okay, next
Boleh lah.
we'll move to the life cycle and pathophysiology.
You tak ada
What?
tunjuk ke? You punya apa tu? Pointer tak ada.
Oh, because I'm not the one who present the
That's
slide.
the witness, tapi tak apalah. Okay ha.
Okay, sorry, doctor. So for the life cycle and pathophysiology, why I include this in one slide? Because when we are understanding the life cycle of the plasmodium parasite, it means that we are understanding the pathophysiology as well. So we start with number 1, where the female Anopheles itself. So the infected female Anopheles has thousands of sporozoites in their salivary gland. So during blood meal, they will inoculate these sporozoites into human hosts, and then this sporozoite will travel into the liver cells and infect the liver cells. So this they will start the exoerythrocytic cycles. So then they will mature into the schizon, where this part of life cycle produce no clinical symptoms. And then after a period of time, this schizon infected liver cells will rupture and releases thousands of merozoites into the bloodstream. So this merozoite will infect the red blood cells, and the period where the before the merozoites infect the red blood cells is known as pre-patent period. In this pre-patent period, the malaria parasites can be detected. Next, after they invade the red blood cells, they will start the erythrocytic cycle, and then they will mature into schizon. Once again, after the schizon infected erythrocyte, number I see number 6 there. Schizon infected red blood cells will rupture and produce clinical symptoms, because as these red blood cells rupture, they will also release the toxics and also parasites metabolites, and this will stimulate the production of cytokines. So these cytokines will increase the body temperature, resulting in fever. However, some of the merozoites also mature within the red blood cells, producing the gametocytes, the number 7. This gametocyte, if ingested by the female Anopheles, will reproduce sexually. Okay, next slide. Okay, next we move on to the risk factors. So I divide the risk factors into 2, the endemicity and also special group. So for the endemicity, residents in or travel to endemic malaria areas has higher prevalence to get malaria infection. And then we have the workers in endemic areas such as the construction site, plantation. This includes the loggers and the tappers. Next, for the special group, we have the adults that have no immunity against the malaria infection, because previously they have no exposure to malaria. Next, we have the young maternal age, because they have altered immunity. And next, we have the young children, especially under 5 years old, and this is reported by WHO to have to be a most vulnerable group to be affected from malaria infection. Next slide. Okay, next I will talk about the clinical features. For clinical features, I will dive into the sorry for that. I will divide into the malaria paroxysm, where in this malaria paroxysm we have 3 stages. The first stage is the cold stage, and the second stage is the hot stage, and the last stage is the sweat stage. In the cold stage, the patient that have malaria infection will feeling of intense cold, and they will produce vigorous shivering. And this stage lasts about 15 to 60 minutes. Then the patient will enter the hot stage, where in this stage, the patient will have intense heat, dry burning skin, and throbbing headache. And this stage lasts about 2 to 6 hours. Then patient will enter the sweat stage, where the patient will have profuse sweating, declining temperature, and blood pressure may drop, causing the orthostatic hypotension. Patient also will have exhausted and weak, so they tends to sleep more at this stage. And then this stage lasts about 2 to 4 hours. Next slide. Okay, these are clinical features that we are looking for according to states. I divided into uncomplicated malaria infection and also severe and complicated malaria infection. For uncomplicated malaria infection, it means that it is a symptomatic malaria without signs of severity or evidence of vital organ dysfunction. This evidence of severity comes from the clinical and laboratory investigation. And usually in uncomplicated malaria infection, patient will have symptoms that are non-specific, such as the fever, nausea, vomiting, and also dry cough. For the severe and complicated, it usually manifests with one or more clinical features in the pictures. So patient in the severe and complicated malaria, we have impaired consciousness or unrousable coma, fever with multiple convulsions, circulatory collapse. So in the physical examination, we will find the patient have a weak and rapid pulse, extreme weakness, which cause the patient not able to sit or stand without assistance, hemoglobinuria, decreased output, severe dehydration, abdominal bleeding because of the thrombocytopenia, jaundice because of the intravascular hemolysis, and also pulmonary edema. For the pulmonary edema, the patient will develop the respiratory distress and deep breathing. And also patient will have respiratory collapse. The important manifestation is the shock, where the patient, because of the parasitemia in the blood. Next slide. Okay, for the complication, actually there are a lot of other complications that caused by malaria infection. But for today's seminar, I'll focus more on 4 main complications caused by malaria infection. First, we have the cerebral malaria. So cerebral malaria is the most common and most severe complication caused by the malaria infection. This happen due to vascular occlusion, especially in Plasmodium falciparum, because the red blood cells that are infected with Plasmodium falciparum will have the ability to rosette, which means that it can become sticky and attached to other normal red blood cells and form a clump of red blood cells, and also cytoadherence, where the infected red blood cells will adhere to the endothelial cells of the blood vessels, and this causes the vascular occlusion. When the vascular occlusion, this will cause the organ hypoperfusion. So the most vital and affected organ, brain. Next, we have the anemia. Anemia in the malaria infection can be occur due to the intravascular hemolysis that results in black water fever. And this black water fever can cause the renal impairment, as the hemolyzed red blood cells will left the pigment that will damage the tubular cells. Other than that, anemia also can be caused by the destruction of red blood cells that can occur when the red blood cells phagocytose the plasmodium, and also autoimmune destruction. Next, we move to the pulmonary edema. Pulmonary edema in malaria infection caused by tissue hypoxia. As I mentioned before, malaria infection can cause vascular occlusion. So this one of the organ, aside from the brain, one of the organ that are affected due to by the vascular occlusion, also our lung. So why, how does tissue hypoxia cause pulmonary edema? Okay, when tissue is lung parenchyma is hypoxic, so this means that partial pressure of oxygen in lung is decreasing. So how our body react to this condition is that our body will increase the blood pressure, and this will cause pulmonary hypertension. So pulmonary hypertension will result in the capillary stress failure that will cause capillary to leak. This then will cause the edema. Next, lastly, we move to the hyperreactive splenomegaly, where hyperreactive splenomegaly is a massive enlargement of spleen that this occurs due to exaggerated immune response. As we know that our spleen is one of the organs that involves in our immunity. Next slide. Okay, for the congenital malaria. So actually, congenital malaria is uncommon.
You just mentioned a bit lah, malaria. Okay, finish. Next.
Okay, okay. Next slide. Okay, so for the investigation, in all settings, clinical suspicion of malaria should be confirmed with a parasitological diagnosis. So the most important investigation in malaria infection is blood film for malaria parasite. So for blood film malaria parasite, we have thick and thin microscopy test, where for the thick, we do to detect the presence of the malaria parasites, which is Plasmodium, and for the thin, we do to identify the species of the malaria, because different species will have different management. Next, we have the full blood count. So the most significant finding in the full blood count in malaria infection is the thrombocytopenia. That's why patient with malaria infections, in severe malaria infection, will have abnormal bleeding. And next, we have blood urea and serum electrolyte. So the sodium, calcium, albumin are low, because we know that malaria, one of the complications of malaria infection, also renal impairment. And next is the CRP level, because that will increase because of there is inflammation and the infection occurs. Next, we have the liver profile. For the liver profile, bilirubin is often raised, and the in the context where normal liver, this is the jaundice is related to the hemolysis. However, if we find that the liver enzyme is elevated, we might also suspect the other diagnosis such as viral hepatitis. And next, for the blood glucose will be lowered, because we know that malaria parasite will consume our blood glucose for their nutrition. Next slide. Also, we have the polymerase chain reaction. We do not do polymerase chain reaction in all cases. We do for the reasons that are stated in the slides. And then we have rapid diagnostic tests, which we do for to detect the parasite antigens such as the lactose dehydrogenase, aldolase, and also HRP2. Next slide. Okay, for management in pediatric patient, usually, basically for management in pediatric patient is more or less the same as adult. Just the dose is adjusted according to age and weight. So for today, I will not talk about the dosing because it will take a lot of time. I will talk about only about the drug availables and also the factors that we need to consider before we choose the drug. For chloroquine, for the mechanism of action, it inhibits the action of build-up heme polymerase, where this heme polymerase is actually the toxic heme produced by Plasmodium. For the side effect of chloroquine, we have the retinopathy, muscle weakness, and toxicity in children. Next, we have artemisinin derivatives such as artesunate and artemether. So this drug act by producing the free radicals species that kills the parasite. And the side effect, it has few side effects such as cough, headache, nausea, and vomiting. For mefloquine, it acts as the, I forgot to mention, in artemisinin, it is usually not administered as one drug only. It is administered together with other drug, and most commonly mefloquine. And this therapy is called artemisinin based combined therapy. Next, we move to the mefloquine. Mefloquine acts as blood schizonticides, where it acts by producing swelling in the foot vessels of the falciparum. Hence, the nutrition of the falciparum will be disturbed. Okay, for the side effect, we have myalgia and abdominal pain. Okay, next slide. Okay, the other drug is quinine. Quinine is effective for chloroquine-resistant Plasmodium vivax and also Plasmodium falciparum. For the side effect, it has quite severe side effects such as thrombocytopenia, hypotension. And then for primaquine, we do for the mechanism of action is not well understood, but it is important co-drug with chloroquine. Next slide. Okay, these are the drugs that pictures are showing different drugs acting on different stage and different location. Next slide. Okay, so these are the factors. So the factors that we need to consider before choosing the drug is malaria species, because not all species.
Forget about it. Forget about it.
Okay.
Dr. Ye don't need to know all these things.
Okay, thank you, Doctor.
Okay, there are a few things. I found out you all still didn't get it. I'm not impressed, you know. You say that, the cause of severe malaria is because of the white blood cell, the red blood cell is in the become very clot very highly very decrease in blood, very slow blood flow in the there's slow blood flow in the cerebral blood vessel, because of the blood become relate phenomena, we call it, it become, the RBC become close, become adhere to each other, relate phenomena, we call it endothelium. I'm not interested with that. What I'm interested is that the patient with cerebral malaria come with this presentation: headache, lethargy, seizure, right? And then one of the clinical seizure, that is what I want. Clinical symptoms. I want the symptoms, the sign and symptoms of cerebral malaria. That's what I want. Bukan the pathophysiology is not important to me of your pathophysiology. Yeah, it's the clinical sign and symptoms. Why you say the child having cerebral malaria? That is what I am interested of. At your level, I don't interested with the pathophysiology or all those things. So, but any other patient with anemia, black water fever. Why you call black water fever? Because passing the urine color is white. Yeah, all the signs symptoms. So urine become blackish, and anemia, jaundice, all those things we want. Yours still goes theory in which you're going to make you all suffer, because so many things, or so details. Next presenter, still go to, we want clinical symptoms, signs and symptoms.
Okay, so I'll start now. Okay. So, Assalamualaikum warahmatullahi wabarakatuh. I'm Nuridin Nabila binti Muhammad Isham, match number 1811110. So today my topic of presentation would be diphtheria and also pertussis.
Topik apa?
Diphtheria and pertussis.
Okay,
I think I have problem with Okay, I'll just present like this because I've got technical problem.
Ah,
So ada technical problem, so I cannot like present.
siapa jaga slide ni? You ke siapa?
Me.
You cannot control your own slide.
Tak boleh present, tak boleh tekan next slide. So
Kenapa?
kejap. I'll try again. Wait.
Kandidat siapa sebelum you siapa? Boleh? Can you change the slide? Is it computer or what?
I think it's my computer. Yeah.
Tak apa, somebody else present dulu. Siapa presenter? Next presenter siapa?
Doctor,
Hmm.
I think what Edina meant is she cannot make it in a slideshow setting. She still can present the slides, but
You
cannot
can
make
change the
it
slide
in.
or not? Because I want to see the slide.
I can show the slide, but I cannot make it into slideshow.
I
Do you want
think
to
it's
do?
okay.
Tak apa lah, as long as you can show the slide. Okay, present lah. Tak payah buat slideshow. Okey Sini. Boleh tukar slide macam ni?
Boleh.
Okey dah. Penting tukar slide sudah. Okey
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Edina. Matric number 1811110. So today my topic will be diphtheria and pertussis. So this is my presentation outline. So diphtheria is a serious infection that caused by a strain of bacteria called Corynebacterium diphtheria that makes toxin which is poisonous to human body. It is an aerobic gram-positive bacillus that produces toxin. So when the bacillus itself infected by a specific virus that carry genetic info for the toxin. It is known as infection that causes local disease with membrane formation, or you guys know it as pseudomembrane formation, affecting the nose, pharynx, or larynx, or systemic disease with myocarditis and neurological manifestation. For epidemiology of this disease, diphtheria occurs worldwide, especially in countries with suboptimal vaccination coverage. And the only reservoir for Corynebacterium diphtheria is human, and they are usually asymptomatic. The transmission of this disease is most often from person to person through respiratory droplets and may also occur from exposure to infected skin lesion particles soiled with discharge from these lesions. In 2017, there is a total of more than 8,000 cases of diphtheria were reported worldwide, and it is the most since 2004. While in Malaysia, in 2019, diphtheria cases was 16. But it is count as fluctuated substantially in recent years because it tends to increase through 2000 to 2019 period ending at 16 in 2019. Next one, for pathogenesis of the disease, I'm not going to explain detail just because we have learned it through BMSCs, right? So just to mention, there is 3 functional region that is involved in this pathogenesis, which is heparin binding epidermal growth factor, translocation region on the B subunit, and also catalytic region on the A subunit. So the one that is actually causes disease in the human body is the toxin itself, not the bacteria. Okay, and the bacteria, like I mentioned before, it is spread from person to person, which is through respiratory droplets, from coughing or sneezing, or from touching infected open sores or ulcer. So you can read this later when all of this mechanism happen, it will then later lead to inhibition of cellular protein synthesis. So when there is inhibition of cellular protein synthesis, it will lead to tissue destruction and also pseudomembrane production that can also further lead to myocarditis, neuritis, and paralysis. For signs and symptoms of diphtheria, it mainly can infect respiratory tract and also the skin. The incubation period is around 2 days. And also I want to mention the signs and symptoms of diphtheria depends on the site of infection, immune status of the patient, and also the virulence of the organism. So for respiratory diphtheria, the patient can experience weakness, sore throat, mild fever, swollen gland in the neck, and also exudative pharyngitis. For exudative pharyngitis, it will actually will evolve into thick pseudomembrane that composed of bacteria, lymphocytes, plasma cells, fibrin, and also dead cells. For cutaneous diphtheria, the patient will first develop papules, which then the papules will further develop to chronic non-healing ulcers. Next one, which is investigation. For the first basic investigation that we could do is full blood count. So the findings that we can find in full blood count is leukocytosis, which is increase in white blood cell count, and then we can also do microscopy gram staining, but it is unreliable because the metachromatic granules that we can found in this bacteria is not really specific for Corynebacterium diphtheria. And then for culture, it is used for confirming the diagnosis of diphtheria. Of course, we have to collect specimen from nasopharynx and also throat, and then we can inoculate them into non-selective and also selective agar plate. The next one, for toxigenic testing, we can do PCR as alternative method in detection of exotoxin gene. So we can detect the tox gene that is present in the toxin that is in the bacteria. Okay, plus this is also rapid and specific. Next one, for treatment and management. Early administration of diphtheria antitoxin to specifically neutralize the exotoxin before it is bound by the host cell. And then we should also give antibiotic therapy with penicillin or erythromycin used to eliminate C. diphtheria and terminate the toxin production. And then for patient, they should have a bed rest, isolation to prevent secondary spread, and also maintenance of an open airway in patients with respiratory infection. Even after the recovery, immunization with toxoid is required because most patients fail to develop protective antibodies after a natural infection. Next one, for prevention and control. The first one, for symptomatic diphtheria, it can be prevented by actively immunizing people with diphtheria toxoid. And then for pediatric patient, give them 4 injections with pertussis and tetanus antigen at 2, 3, and 5 months, and also recommended to give them booster at 18 months. Also, we cannot ignore for people who have close contact with patients with diphtheria disease because they are at risk of acquiring the disease. So collect nasopharyngeal specimen for culture from them, and also give them antimicrobial prophylaxis with erythromycin or penicillin, and it should be started immediately. Next one, for pertussis. So pertussis is known as a whooping cough. It is a highly contagious respiratory disease that caused by Bordetella pertussis, and it is a gram-negative rot. For mode of transmission for pertussis, it is spread from person to person, and usually by coughing or sneezing, or when spending a lot of time near one another where you share breathing space. For epidemiology of this disease, it is a human disease with no other recognized animal or environmental reservoir. Also, it occurs worldwide, endemic worldwide, and it is believed that adolescent and adult act as a reservoir and often cause of infection in infant. In Malaysia, the incidence of pertussis has been less than 1 per 100,000 populations for the past 15 years. It is attributed by good immunization coverage. For pathogenesis, also I will not explain it too detail. Just want to tell that this is a toxin-mediated disease and the incubation period around 7 to 10 days. So the basic, summary, how it causes disease is first by bacterial attachment, and then there will be bacterial proliferation, which will then they will have production of localized tissue damage, systemic toxicity. Yeah, that's how from systemic toxicity they will develop paroxysmal stage of the pertussis. You can read it later, okay? And then for signs and symptoms of pertussis, we can divide it into 3 stages. There's 3 stages. For first stages, it is catarrhal stages. The patients can experience common cold, rhinorrhea, sneezing, malaise, anorexia, and also low-grade fever. This is because at these stages, there is highest risk to their contact, which means there is peak number of bacteria is produced at earlier stages, and it happened for 1 to 2 weeks, which will then later paroxysmal stage begin. So for paroxysmal stage, it developed, the duration of this stage is around 2 to 4 weeks. So the patient will experience classical whooping cough paroxysm, which is a series of repetitive cough followed by inspiratory whoop, and it is frequently terminated with vomiting and exhaustion. So the appearance of the patient can be cyanosis, or in young infants, they can experience apnea. So at this stage, these symptoms happen because the ciliated epithelial cells are extruded from respiratory tract and the clearance of mucus is impaired. The last stage, which is convalescent stage, this stage marks a gradual resolution of pertussis disease. So it is when the paroxysms diminish in number and severity, and it can last from 3 to 4 weeks or longer than that. Next one, for investigation of this disease, of course, we have to do a full blood count. So upon this investigation, there will be marked elevation of white blood cell with lymphocytosis. And then for culture, we can do it because it is gold standard and particularly useful for confirming pertussis diagnosis. For PCR, it is also we can also do it because it is a rapid test and also has excellent sensitivity to diagnose pertussis disease. The last one is serological testing. It is useful for confirming diagnosis and also more useful for diagnosis in later phases of the disease. This is because optimal timing for specimen collection is 2 to 8 weeks following cough onset when the antibody titers are at their highest. I've provided like a timeline of optimal timing for diagnostic testing, so you can refer it here. There is culture, PCR, and also serology. The next one is treatment and management. So for pediatric patient, of course, nursing supervision during paroxysmal and convalescent stage of illness is important. And then the doctor should prescribe erythromycin for 14 days and should be given in catheter stage to stop the progression of disease and supportive care during this paroxysm. And if in case the patient is unable to tolerate microlides, then the doctor can prescribe them trimethoprim, sulfamethoxazole, or fluoroquinolones. And also for person that have significant exposure to infected patients, provide them with a prophylaxis. The last one for prevention and control, the important one, we have to follow the immunization schedule for Malaysia and implement control measures to prevent transmission of the disease. Again, for pediatric patient, give them acellular vaccine administered in combination with tetanus and diphtheria vaccine at 2, 3, 5 months and also booster at 18 months. We cannot ignore the person who have close contact with those who have pertussis disease. So give them post-exposure antimicrobial prophylaxis such as azithromycin. So this I've provided the latest immunization schedule for Malaysia. That's it for my presentation. Thank you.
Okay, but then as usual, you didn't explain so much about the clinical. Diphtheria, they got one first week, second week, third week, 4 weeks. And the first week, second week, and then what you do? What is the management of basically about diphtheria? What the complication of diphtheria? And when they got airway obstruction, the severity, and then the second thing is the septic toxicity. Involve me the cardiac one, second the CNS atau the nervous system. With the cardiac, many of them die because of the effect of the cardiomyopathy. This is the thing that we want, a bit more detail about the name. And then the same with the pertussis. The presentation mainly is a coughing. The coughing, and then the coughing is paroxysmal coughing. Why is it whooping? Why is it in young children you don't hurt the whooping? The whooping. Why is it when the whooping you can hurt, not at the early present the young children? And why is whooping like? Why we call whooping? Kenapa dia whoop? That is the thing they're interested. We're interested to know. And then development, why is it they become respiratory distress? Respiratory distress, develop secondary pneumonia, how many percent develop the secondary pneumonia, and so on. This is the thing that you have to explore. Explore more of ni. Buku apa you pakai semua ni? Mereka buku yang pakai ni buku. I found out you all terlalu when you read, that doesn't mean you want to tell us everything, Problem with you all, when you read, you want to tell us everything. That's why I want to next one tahu lah. You ada briefing tak seminar? I nak limit 25 minutes saja for each seminar, so that you all know how to think to present which one important, which one not so important at your level. Because some of you present at the level of postgraduate, which is not necessary for you all to know. And then because of that, you suffer because you look so complicated. Actually, simple, the thing you need to know. Who's the next presenter?
Ni, doktor. Ni, Hanis.
Hanis, mana? Mana Hanis? Betul sepuluh. Hanis, okay.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Hanis Menti Hamdan with branch number of 18108816, and I will present about leptospirocin. And this is the contents for my presentation today. And the definition of leptospirosis is actually the widespread of zoonotic infection that caused by aerobic motospirochete of genus Leptospira, which commonly occur in both temperate and tropical regions. The causative agent for leptospirosis is Leptospira interrogans. It is a gram-negative bacteria and seen best with dark field microscopy. It is actively motile and the shape is long, slender, tight cord, spiral corkscrew-shaped rods. You can see the picture here. As for epidemiology, the incidence in the tropic is approximately 10 times higher than in temperate regions. A modeling exercise by WHO estimated that there were 873,000 cases worldwide annually, with 48,600 deaths were recorded. In Malaysia, as we can see in the graph, the lowest case recorded were in 2004, and the highest case is in 2014 with the highest death recorded. This graph showed the leptospirosis cases by state in Malaysia. As we can see, the lowest case is in Perlis, and moderate case is in Kedah, Sabah and Kelantan, and the highest is in Selangor. Next, I will explain about the mode of transmission. The animal that bring leptospirosis is rats, mice, wild rodents, dogs, and cattle. And these above animals can excrete the leptospira both in active infection and asymptomatic stage. In order for the leptospirosis to infect the human, and it has to be direct contact with the mucus, skin, or conjunctiva. It also can be transmitted by ingestion of contaminated food and also water. From this image, we can see that the leptospira is being transmitted via the urine of the infected animal, and the urine can go into the water and soil and contaminate the water, and then other animal and also human come into direct contact with the contaminated water and soil and get infected with leptospira.
Semula
Yes.
mention lah, present uritis, meningitis, myocarditis.
And I will explain it in the clinical manifestation.
Okay ha.
And then I will explain about the people which have higher risk in order to get leptospirosis. First is sewage workers. This is because they handle the sewage and also excrement. Therefore, there are probability that the sewage already contaminated with leptospira interrogans. If they get into direct contact with the sewage, they will get the infection. Next is pet shop worker. Okay. There are probability that the animal itself already infected with leptospira. When the worker handle the animal waste and get into direct contact with the waste, and then the worker can get infection. Next is disaster relief workers, especially during floods, because there are probability that the water floods already contaminated with leptospira. Next is people involved with outdoor activities such as water recreation activities and jungle trekking. Okay, for example, like the waterfall. Maybe when the tourists get into the waterfall that already infected with leptospira interrogan, they can get the leptospirosis. As for pathogenesis, the leptospira enter the human through the mucous membrane. And after the penetration, they will circulate in the bloodstream to body organs such as liver, kidney, lung, as well brain. And then it will further cause endothelial lining damage of small blood vessels. And then after that, it can cause the secondary ischemic damage to end organs such as pulmonary hemorrhage and renal failure. After the bacteria already invade the renal organ, it can cause renal colonization, and leptospiroria will occur to that patient, and the organism will shed in the urine and exit from the human body. Okay, I will explain about the clinical manifestation of leptospira. Okay, leptospira have two types of manifestation. The first is anicteric leptospirosis, which occur in 90% of cases, but it is less severe, and the mortality rate is less than 2%. The second type is icteric leptospirosis, it is rare. It occurs in 10% of cases, but is more severe and common in adults. The mortality rate is 5 to 15%. Okay, the unitary leptospirosis is a self-limited mild flu-like illness, and there are two distinct phases of illness observed in leptospirosis. The first is a septicemic phase, which occurs 3 to 7 days after the infection. And then the second phase is an immune phase, which is the delayed phase. Okay, during the septicemic phase of unitary leptospirosis, the patient will have abrupt onset of fever with rigor. Okay, some of the patient also may have lethargy, malaise, nausea, and vomiting. Some patient also may have severe debilitating myalgia, which is most prominent in the lower extremities, lumbar cervical spine, and also abdomen area. Okay, the patient with leptospirosis will have conjunctiva sufficient with photophobia and orbital pain. As you can see in the picture, okay, the conjunctiva sufficient is characterized by the redness of the conjunctiva that resembles the conjunctivitis, but it does not involve the inflammatory exudates. The patient also may have hepatosplenomegaly and generalized lymphadenopathy. Okay, 10% of cases may have rashes such as erythematous Imaculopapular, urticarial, petechial, and also purpuric rash. For the renal manifestation, during this phase, the patient may have pharyngitis, pneumonitis, arthritis, carditis, cholecystis, and also urgitis. During the second or immune phase of unitary leptospirosis, the patient will have recurrence of fever. The recurrence of fever indicates the onset of the immune phase of unitary leptospirosis. And aseptic meningitis is the most important clinical syndrome observed in immune unitary stage. Meningitis symptoms develop in 50% of patients, but meningitis usually will last a few days, but occasionally will last 1 to 2 weeks later. Okay, when the bacteria already invade the cerebrospinal fluid, the patient may have cerebrospinal fluid abnormalities, include a modest elevation in pressure and pericytosis with early polymorphonuclear leukocytosis. The patient also may have unilateral or bilateral uveitis can occur. The uveitis is a form of eye inflammation. It affects the middle layer of tissue, which is the uvea area. Okay, next is the icteric leptospirosis. It is also known as Wells syndrome. Now, this is the severe illness characterized by multi-organ involvement or even failure. As for septicemic phase, during the icteric leptospirosis, it is similar to unitary leptospirosis that I had explained earlier. And during the immune phase of the icteric leptospirosis, the patient will manifest with jaundice. It indicates that the bacteria already invade the liver organ. The patient also may have renal failure when the bacteria invade the renal organ. So 50% of the patient may have thrombocytopenia. In feminine cases, hemorrhage and cardiovascular collapse also may occur. The hepatic involvement leads the patient to have right upper quadrant pain, hepatomegaly, direct and indirect hyperbilirubinemia, and modestly elevated serum levels of hepatic enzymes. But it usually will resolve after recovery. The patient also may come with abnormal findings on urinalysis such as hematuria, proteinuria, and CAS, and azotemia with oliguria or anuria. Okay, and 16 to 14% of cases will have acute kidney failure, and this is the principal cause of death, usually due to sepsis. And 90% of cases will come with abnormal electrocardiograms, but the congestive heart failure is uncommon. Okay, next is differential diagnosis. Okay, leptospirosis may be difficult to differentiate it from other infectious illness because most of them have quite similar features. Conjunctival suffusion is one of the most reliable clinical features in order to distinguish leptospirosis from any other infectious illness. This is because conjunctival suffusion usually occur in leptospirosis. Okay, as for malaria, chikungunya, and dengue, they also have common clinical features with leptospirosis, such as fever, malaise, and fatigue. Therefore, we need to do further lab investigation in order to differentiate them. As for scalp typhus, it also a disease that usually happen in tropical region where the leptospirosis may occur. The scalp typhus also share the same clinical features with leptospirosis, which are fever and also myalgia. For scalp typhus, the fever will last in a longer period that can last from 9 until 19 days. The leptospirosis also can mimic the infections of Rickettsia typhi and Salmonella typhi. As for hantavirus, it can manifest the renal syndrome as well as pulmonary syndrome, which is similar with the renal and also pulmonary complication that the leptospirosis patient will manifest. The next is investigation. Okay, microscopy agglutination test is a gold standard of serodiagnosis for leptospira. Okay, we must get at least 4 increase in titer in fat sera in order to confirm the diagnosis. It usually appears in the 12th day of illness. Next, we can do IgM ELISA. Okay, IgM ELISA is optional for MAT, and it is function in order to detect the IgM antibodies, which may indicate that that patient have resistant leptospirosis. Okay, and then this patient's serum may be positive 5 to 10 days after the onset of the symptom. Next, we do PCR. Okay, PCR assay will target the gene unique to pathogenic leptospira species, and then it is increasingly available, and we use it for get the accurate diagnosis of acute leptospirosis. After that, we also can do culture of the organism. First, we can do self-S culture. The leptospira can be found in 10 days of illness. For urine culture, the leptospira can be found in first 2 weeks. As for blood culture, it usually will be positive in the first 10 days. But blood culture is insensitive, and the isolation only successful in 5 to 50% of cases only. Next is management. For children 8 years old and above, we give penicillin G, cefotaxime, or doxycycline. As for children younger than 8 years old, we give ampicillin or amoxicillin. For less severe cases, we treated them with oral antibiotics such as doxycycline, tetracycline, ampicillin, or amoxicillin. For severe cases,
Kenapa
we
tak boleh
treat them
beri
with high
penicillin
doses.
G for less than 8 years old?
Yes, doktor.
Kenapa tak boleh beri penicillin G for less than 8 years old? You ambil mana ni?
Malaysian guidelines, leptospirosis.
Bukan PIS protokol? Biasa dia kasih penicillin tu, penicillin G tu, even less than 8 years old. Tak apalah, continue lah. Continue. Continue lah, tak apa.
Okay. Alright. For azithromycin, it also is as effective as doxycycline. It can be used as alternative in patients whom doxycycline is contraindicated, such as pregnant mother. As for severe cases of leptospirosis, it can infect many organs that can lead to multi-organ failure. Therefore, we should give supportive therapy and careful management such as dialysis and mechanical ventilation. As for prevention, we have to target the source of infection and the transmission of the infection between the animal source and as well as the human host. Okay, for human vaccination, it is still in development and not widely available. Therefore, we should vaccinate the animal in order to control the source of infection. Okay, next, we have to avoid the contaminated water areas such as the contaminated waterfall. Okay, next, we have to advise the public in order to keep their homes and premises free from the rodents. Next, promote cleanliness at the recreational areas and food premises. When the premise and also recreational area is clean, therefore we can reduce the probability for the animal to come to that place. Therefore, we can we can reduce the leptospirosis case. Next is wear occupational hazard suits such as rubber boot. This is in order to protect the occupational hazard worker, especially during flight. This is in order to prevent them from getting into direct contact with the contaminated flight water. And that's all from me.
Okay. Any other questions? Okay. Cuma next time your clinical macam like leptospirosis, don't much detail on the pathogenesis. It's more of the concentrate on the clinical and the clinical presentations. Management also no need so detail. And for you all, management is just to know basic only managements. What we want to know is clinical, because your posting now is clinical posting. If you do year 1, year 2, yes, if you want to know all the pathophysiology of those things, pathogenesis, tapi that thing is over already. Okay, any question? No question, okay, finish.